Hey, good morning. I'm Stuart Long, like you said. We're going to talk about thoracic aortic aneurysms. And as Joe was saying, it's really a multidisciplinary approach that's been one of the advantages of the Heart Institute. Myself, Dr. Sands, actually one of the general surgeons that does vascular surgery. Dr. Swanwickson is involved, and Dr. Tata as well. We all can come together as a team and offer a less invasive approach to fixing aneurysms of the thoracic aorta, which I'll show you later. Previous to this required a pretty large magnitude of an operation that many patients that had indications for the operations, quite frankly, could not survive the impact of the operation due to the physiologic impact of a large incision and replacing the aorta. The new technology, in essence, fixes the aneurysm from the inside. And I'll just have a graft here. I'll show you. It's basically a piece of Gore-Tex like your coat is made out of, just fashioned into a tube, and that technology has been designed to just place this inside the blood vessel. So today I'll review some history, some facts about aortic aneurysms, discuss some of the open approaches, as well as this newer technology. So an aortic aneurysm is basically a dilation or a bulge of the aorta. And the actual definition is when the size or diameter is 1.5 times greater than the normal aorta. The normal aorta is roughly about 2 centimeters. Here we see the descending thoracic aorta. And as a cardiac surgeon, this is in the chest. It's essentially from the left subclavian artery, which is the artery that goes to the left arm, and defined where the aorta then crosses into the abdomen through the diaphragm, which is basically the muscle that separates your chest from your belly. And here is the ascending aorta coming out of the heart. You have the aortic arch, and then once it crosses over and becomes down, we term it the descending aorta, and that just means it's the part of the aorta that's going down versus going up. And it just allows us to classify and discuss the aorta in terms of what treatment is necessary. And essentially, like Matt was saying, how do you get there? The heart, most commonly, you go through the front, as a sternotomy. This ascending aorta is actually best approached through the front or sternotomy, as well as the aortic arch. The descending aorta, surgically, is best approached through the left chest, just how it lays out. And so we're talking about bulges or aneurysms of the descending aorta. So roughly 15,000 to 25,000 people in the United States are diagnosed with a thoracic aortic aneurysm. Again, this part of the aorta coming down here. The aorta is the major blood vessel that leaves the heart and takes blood to the body, and there are branches off the aorta that supply blood and oxygen to the rest of the body. So here is a picture of the heart valve, and if you can imagine, the heart would be here as the pump, as Dr. Berry was saying. It's a very efficient pump. And essentially, the aorta is basically the garden hose attached to the pump. And it comes up out of the heart, and then this branch here gives blood. It actually goes to the right side of the brain and into the right arm. This branch here gives blood up to the left side of the brain. This branch here, if you can imagine, go into the left arm. There aren't too many branches coming off the main aorta here. There are some that go to the spinal cord and to the lungs. And then you have some branches below where the diaphragm would be. This would be an artery that goes to the liver and some of the major intestines, as well as this one. And then these are pictures of the kidneys. Some blood flow going to the kidneys. And actually here is the part of the aorta, which is in the abdomen. And then here the aorta splits into two major tubes. One goes to the right leg and one goes to the left leg. So this is a pretty simplified drawing, but essentially the aorta is the major blood vessel of the whole body. It runs out of the heart, down the chest, through your abdomen or your belly, and then goes to the supplies both the arms and legs and everything else in your body that needs blood, and it carries the oxygen. Well, this is bulging because it's a picture describing aneurysms, and essentially I'll get farther, but the cause of the bulging is basically a weakening of the tissue. So it's kind of it's a mechanical failure of the strength of the tissue. It's like, imagine your garden hose getting weak over time, baking out in the sun, and every time your garden hose gets kind of sun faded and maybe somebody clamped on one end, put a high pressure, it may start bulging. like any other tube, or maybe think about your pipe, may start kind of getting weak over time. So this picture is just kind of showing where the aneurysms are in the entire aorta. Most commonly, they're actually in the belly, or the abdomen, so 63%. These are also life-threatening problems as well, and can be fixed by similar technology with these endografts. Today we're focusing, more of my specialty is the thoracic aorta, and actually if you look at it, all this is roughly 40%. Most of the aneurysms in the chest are in the descending part. There are some in the ascending and the arch. We're finding more and more aneurysms in time, and now more in 2009 say than we did 20 years ago. Part of it is that people are living longer. So as you live longer, things wear out, things dilate. The waistline, the aorta, all sorts of things get bigger. And also, really, I think one of the main reasons we're seeing more aneurysms is more people are getting chest x-rays, CAT scans, ultrasounds. So we're finding them kind of incidentally. Somebody comes in with a minor complaint or a little bit of pain here or there, they get a CAT scan, then we find an aneurysm that's too big, and we say, hey, this ought to get fixed. The reason to fix them is that they can kill you if they rupture. Just like if a balloon gets blown up too big, eventually it can only hold so much water or air, it's going to pop. Same thing with the aorta. Roughly about 6,000 people die every year from these aneurysms. If you leave them alone and don't treat them, if you just look at the 5-year survival, it ranges from 20 to 40%. So in many instances, you'd be better off having many types of cancer than having one of these aneurysms. There are about 18,000 of these procedures are done in the United States. And interestingly, people that have aneurysms in the chest, about 12%, people that have aneurysms in the abdomen, about 12% have aneurysms in the chest. And they also kind of can run in families as well. Most people that have these aneurysms are asymptomatic, meaning they don't know they have it. It's not causing any problems. They're walking around essentially with a time bomb inside of them. If you look at them, the probability of rupture or bursting over 5 years is approximately 20% for all aneurysms out there. Once the aneurysm gets over 6 centimeters in the aneurysm that's in the chest, it's about 30%, or 1 out of 3 people will rupture their aneurysm over that time period. Well, that's the next part. What happens then? Right here. 94 to 97% are fatalities or deaths do not survive the rupture. So over 3/4 die within the first day after the rupture. So that's the impetus to what we call prophylactic treatment, so treating it before ruptures. And essentially, the guidelines come on based on when the treatment is not as bad as the disease, leaving it alone. So we know over time, and I'll show you some slides later, that as they get large, the probability for rupture or killing people increases, and therefore it's indicated to treat them, because all treatments do have some risk. Some of the risk factors, a big one is family history. If somebody in your family's had abdominal aneurysm or thoracic aneurysm, you're more likely to have an aneurysm yourself. It may be indication to get a screening exam from your primary care doc, at least an ultrasound of the abdomen. Smoking actually is another reason. It weakens the tissues of the blood vessels, just like Dr. Berry was saying, smoking's cancer, heart disease. It's also involved with weakening the arteries in the aorta. So if you do nothing else in life, don't take up smoking or quit. That's kind of the bottom line of today for prevention. High blood pressure is a risk factor as well. As you can imagine, the blood pressure is just pushing and pounding on the aortic wall, and if it's weak at all, it just slowly expands. And then age, again, just as things wear out over time, the blood vessels are likely to dilate. So this is thoracic aneurysm. It's called a silent killer. As I was stating before, most folks don't have any symptoms other than the acute onset of pain, and then or back pain, or they pass out, and then many times it's too late when they come in. There are some symptoms that can be referred to thoracic aneurysms. As they grow, they may press on surrounding structures, some nerves, smaller tissue, and cause some kind of vague, nondescript symptoms that can cause you to seek medical attention, and then hopefully will, ultimately be found to be the cause. Hoarseness, if it's aneurysm is pressing on a nerve that goes up to your voice box. You can have some pain in your back as it's growing, pain in your neck or jaw. If it actually gets quite large, you can compress the major vein that drains your head, and you can kind of get some swelling. That's pretty rare. Hypertension is not, it's a very common thing, so not all people that have hypertension have an aneurysm, but it is associated, as said before. The things that we worry about cause a rupture are pretty catastrophic. Acute chest or back pain, cardiovascular collapse, meaning somebody just completely passes out. Coughing up blood or vomiting blood can be presenting symptoms. Normally that's a pretty catastrophic event, meaning the aorta is ruptured and it's eroded into a major structure in the chest, the windpipe or the swallowing tube. So how do we go about finding and evaluating aneurysms? Chest X-ray is a very common modality that gives an indication that there may be an aneurysm there. Somebody gets a chest X-ray for a little shortness of breath or chest pain, some other reason, and we see a little bit of increased shadow where we know the aorta normally lives. It looks a little bigger, fuller, and that normally leads to additional imaging, either a CAT scan or an MRI. Also, many people go in with back pain for routine causes, get a CAT scan or MRI to evaluate their back pain and are found to have an aneurysm. Angiography is a test where we squirt dye in the blood vessels. This is not commonly used now. It's actually diagnosis, but we do use it at the time of the repair. We also find them when people are getting ultrasounds of their heart to look for valve problems, like Dr. Maxwell's talking about looking for the mitral valve. Someone has a murmur, they may get special types of echoes or ultrasounds that could also pick up the aneurysm that's there and present as well. So as I was getting to before, when as the aneurysms grow, the probability to rupture or dissect, can get tears in them, and which also cause problems with increased rupture or cutting off blood flow to the branch vessels, or frankly just to kill people. That's when we recommend repairing them. And it's a little bit of statistics as the probability goes up for rupture, and you compare that to the risk of putting someone through surgery, the not surviving surgery or having a complication from surgery. That's where the recommendations come to repair the aneurysm. So essentially, in the thoracic aorta, clearly 6 centimeters. Most folks recommend that it should be considered repairing unless the patient's extremely high risk or extremely old. There are certain situations where we would watch that, or they may not be a candidate for the repair with the endograft and they may not tolerate open surgery. 5 centimeters is kind of classic indication to repair the aneurysm in the belly or the abdomen. And so the chest, kind of that 5 to 6 range is when we give serious thought to it. Or if the aneurysm is expanding, if it's getting bigger, that makes us worry as well. There are certain aneurysms that have some dissection in them. Now, dissection is when the walls of the blood vessel get a tear in the inner lining and blood flows down and creates a false channel that weakens it. It can cause it to expand and actually as well can be a problem. Or it cuts off blood flow to a branch vessel like to the kidneys or to the intestines or maybe even to the brain. So that can be a major catastrophic event and an indication for urgent surgery in certain situations. And then you combine rupture or dissection or just death. Somebody has an aneurysm and they just turn up dead one day. If you put all that together, the major life-threatening complications, rupture, dissection, or death, you see once you get 6 centimeters, it's pretty high, 15%. And even in some of these smaller areas, if you put it all together, it's 5%. Now these seem pretty high, but some of the risk of open surgery are quite high as well, and there's some risk of fixing these even with the stents. So what are the options? This is kind of a slide of some various options. Basically, you can watch and wait. If it's not, if we don't believe it's big enough to fix, or the patient is particularly high risk for the therapies we have, we may watch and wait. Here's a picture of open surgery. Essentially, the patient, if you can see, this is pretty big incision. You can hardly even recognize the patient. Here's the aorta. The head's up here. This is the aorta running down through the chest and actually crossing into the belly. This incision basically cuts the patient across the chest and down through the rib cage into the abdomen, exposing the entire aorta. So as you see, it's it's a large incision. It's a big impact on many patients. Some of the complications with this I'll get to. One of them, obviously, the lung is in this area, has to be collapsed, has pulmonary problems. Many patients who have aneurysms are smoking and may not be able to tolerate this surgery from a lung standpoint of view or even from a heart standpoint of view. It exposes the abdominal intestines to risk of poor blood flow. It exposes the kidneys to poor blood flow. So there's complication rates of kidney failure afterwards, lung failure afterwards, heart attack. So if you need this operation, it's indicated, and if it's indicated and you don't have a good option for the stent, and this is better than having it rupture and die, but there's no free lunch right here with the open surgery. Here's the other way, is the stent graft, which is really a huge advance in technology, that we can go in, essentially go through the blood vessel and place a stent and exclude the aneurysm from the circulation to take the pressure off the sac and prevent future rupture. This picture here shows our catheter going up through the aorta and around into the aortic arch. This one here shows that we've had to open up a small incision in the lower part of the abdomen and sew on a special graft to bring up the stent, basically. And the stents are quite large. Some of the sheaths that introduce the stents into the body can be as big as one of your fingers. And many times the blood vessels down in the legs, in the groin, are not big enough to bring these stents up without tearing them up, essentially. So we have to go and sew on what we call a conduit or an extra graft to bring the device up. But as you can see, even doing this, it's a much smaller operation compared to opening somebody up all the way. So watching and waiting for the smaller aneurysms that are not expanding, not causing symptoms. These are monitored with CAT scan or MRI, depending on the situation. Every 6 months initially until it's stable, and then many times after that every year, depending on the situation. Open surgical repair, you replace the weakened part of the aorta with a graft. This is essentially a Dacron tube, the same material that ladies' stockings are made out of. And actually, Dr. DeBakey, who Dr. Maxwell referred to, his mother, I think he got the idea from his mother's stockings, which is kind of interesting. But obviously, they're more expensive, they're woven a little bit tighter, and we figured out how to make them not leak blood. These operations many times require the use of the heart-lung machine. They can either be placed on the heart-lung machine through the same incision in the chest, or sometimes through incisions in the groin. The benefits of open repair are pretty well established. Dr. DeBakey and Dr. Cooley, some of the real pioneers of heart surgery back in the 50s and in 60s, worked out these techniques, how to replace parts of the aorta. And compared to untreated patients, if you left people alone, only 20 to 40% were alive in 5 years, compared to roughly 60 to 70%. So not everybody, but a lot better than not operating on patients. The 30-day mortality, meaning the death rate in the first month after elective surgical repair for these large aneurysms, is quite significant. 8 to 20%. High volume centers, are lower down here. If you don't do it very often, you're probably more up there. It also depends on the patient's type of aneurysm, the extent of aneurysm. Do you have to replace the entire aorta or just a localized segment? Morbidity basically is pain and suffering. What patients, have to go through to get their problem or disease fixed. Again, it's quite high, basically 50%. So 1 out of 2 has some kind of problem to deal with, either a problem with their kidneys, their intestines, or their guts, or their spinal cord, meaning they can't move their arms, or they can't move their legs very well. So neurologic complication rate is basically stroke, or paraplegia, or paraparesis, meaning either paraplegia, complete paralysis of the legs can be a complication. There's an artery from the aorta to the spinal cord up high, low down the chest, called the artery of Adamkiewicz. That is can be caused if you have to either replace it surgically, either that blood flow is cut off, or even with the stent, it can still be a problem. So again, a pretty significant thing to worry about if you're getting this problem fixed. A chance of being paralyzed from the operation. And it's not insignificant for the open repair. Average day, this is probably on the short side for open repair, 7 to 10 days. It can be up closer to 2 weeks. The endovascular repair is kind of the main focus of the talk today. Again, bringing a stent up through an artery in the groin or lower down in the belly, and repairing from the inside. You still have to get there. About 20% roughly, or 1 out of 5 patients will require that we do an additional procedure to allow us to access the main blood vessel. Some, so 4 out of 5 we can just open up a small incision in the groin, similar to where cardiac caths are done, and bring the device up. We do use angiographic guidance, so we go up and we inject dye into the blood vessels. I'll show you some pictures later to help us see, and this is where the multidisciplinary team really comes into play, with Dr. Sands being a cardiologist, and sometimes even radiologists are involved. We all kind of work together and bring all our skill sets together to provide this therapy. Basically, the graft on the inside, it has to have a normal piece of artery above and below the aneurysm for the device to work. It excludes the aneurysm from the rest of the circulation. Gore, patients, the similar company that makes your raincoats, is one of the predominant manufacturers of this device. There are other companies like Medtronic that make similar devices. I did some of the initial studies on them and compared this endovascular treatment to the open techniques. They basically took 17 centers, had a large number of patients, and compared basically the 140 patients treated with the endovascular stent compared to patients who had the traditional or old-fashioned, so to speak, open repair, and actually followed them up at 1 year. The study is still going on, looking for 5-year results. At 1 year, the endovascular repair, the stent graft, had 1/5 of the paraplegia or paraparesis rate, meaning your chance of being paralyzed and not being able to move your legs was actually 3% versus 14%, which is a dramatic reduction. Obviously not zero, but much better odds. Paraplegia rate, complete paralysis, was 0.7% versus 8.5%. Also, the chance of dying from the operation was markedly lower, basically 1% versus 6% in this study. These were more selected patients and all comers. As you saw, the chance of dying from open repair, previous studies was in the 8 to 20% range. There are patients that are not candidates for this endovascular stent repair, likely explain the lower mortality rate of the open repair in the study. They did not have any ruptures as of 3 years. They had a lower aneurysm-related death rate through 2 years, a lot less blood loss, less time in the ICU, less time in the hospital, and a much faster return to activity. So we could talk about adverse events, basically meaning bad things that happen after surgery or complications, the kidney failure, the strokes. So if you look at the Gore device, patients much better off as far as not having any sort of complication. And then here, any kind of complication related to the device was seen at 94%. So the device itself, about 6% of problems caused from the device, but actually it's quite acceptable, especially comparing to the open surgery options. A couple points. This is a newer technology. Quite frankly, we don't know the 20-year data as compared to the old technology. So patients need to be committed to having serial or ongoing CAT scans throughout the course of time. Essentially, we get one a month after the procedure, and 6 months. If all looks good, then we can go to every year after that. There's something called an endo leak, which is kind of a unique complication, so to speak, created by this new technology, meaning we repair the blood vessel from the inside, but oftentimes there are little small branches that were feeding from the aneurysm before after. They may kind of provide some blood flow into the aneurysm still. And that, in this study, was 3%. It's generally thought to be higher than that now. roughly somewhere in the 10 to 15% chance range for all comers. This is at 1 year. Many times we can follow those and they will go away on their own. Sometimes they do require additional procedures or even more future stenting. About 2% of patients in the study actually had their aneurysm enlarged over the time, which obviously you wouldn't see in the open repair group because the aneurysm would have been cut out. This may require future treatments, or occasion the patient may need to go from the stent procedure to then maybe in the future actually having it done open. Here I have a couple of cases just to show that what we've done here. This is a young lady who incidentally was found to have an aneurysm. Here's her ascending aorta. This is where her heart valve, you kind of see her heart here. The blood comes up here. The branches up to her head and shoulders. And then the aortic arch, and then the descending. Right here you see kind of a bulge or a defect, or an aneurysm, right beyond this major blood vessel. This one actually goes to the left arm. Likely this was related from an old car accident. If you kind of talk to her, she probably had a car accident and her aorta had been kind of torn or transected at some point, just based on where it is, and kind of led to this bulge here that kind of, fortunately for her, she survived that, and led to kind of a chronic bulge. She's still at risk for this rupturing over time if left untreated. So we came in and we offered her the stent graft treatment. In her case, we needed you have to have a couple centimeters on each side of the aneurysm to get a seal to exclude the blood flow from going in the aneurysm. We had to cover up the major blood vessel going to her arm, which majority of people do tolerate, interestingly. There are other kind of side roads that get reestablished over time. If they don't tolerate it, we can do a procedure where we basically take blood flow from the artery to the neck and do a short little kind of bypass graft and plug it into the artery to the arm. So here's a picture at the time of her procedure. This we kind of have a measuring catheter in the aorta here. You see the bulge. And then here you see the picture with the stent in the aorta. And we're doing some ballooning of it. And then here's a picture, actually just a couple days ago, where she was following up. And you see that she no longer has that bulge here. This little white image here is actually a kind of a picture of her graft. And actually, you can kind of see the blood vessel to her arm. You can't see it here. You still the one to her neck, and then to her arm and neck. This to her left neck, arm and neck on the right side. She initially did have a little bit, her left hand was a little bit cooler right after the operation, but now, I think she's about 6 months since we've done this. Her hand is completely warm and is completely normal. So she's quite pleased. Here's another operation, another patient. This patient had an aneurysm down lower in the thoracic aorta, almost, if you see it's kind of going down close to the belly. The rest of our aorta actually, fortunately up top, was pretty normal. Here's a picture taken at the time of the procedure where we injected dye into the blood vessel, and you kind of see the inner lining of where the bulge is. And the aneurysm is actually bigger than this because there's clot out here that doesn't fill with dye. Here's an artery that goes to her liver and gives a branch to her spleen and some of the other major intestine, stomach. And this aneurysm is actually quite close to that artery, so we kind of have another catheter here to mark that to allow us to try to precisely place the graft and not cover up the artery to the belly. Interestingly, some people are actually covering this up, which hasn't been done too much before, with okay results. We'll see how that pans out in the future, just how we're covering up the artery to the arm. Some people are doing that, covering this up as well. But it's not quite the, if you can avoid it, it's obviously better to leave blood flow going where it was designed to go. So here's a picture after we put the stent in. If you can see again, the aneurysm is excluded. Here's the branches to her intestines and such. You see we have a catheter here that we're kind of taking injecting dye to take the picture in.
It is phenomenal that, that we have in little old Missoula, Montana, that high level of skill. And the piece that is also inspiring to me is that as they share with all of us their knowledge and their expertise, and their wisdom that we come together and we listen to stuff we don't know anything about. But there's something about what they tell us that instills within us a sense of confidence and a sense of gratitude that they are present among us. And as Dr. Knapp mentioned, we all know, at least intellectually, that healing takes more than just the body. And part of my role here at St. Pat's with regard to mission leadership is acknowledging that we have to create an atmosphere here that goes beyond physically manipulating your body so that you're fixed in some way, but on a deeper level, that there is healing that happens. And the only way that healing happens is human being to human being. Bringing the tremendous skill that everyone has with a desire of the heart, which is compassion, to extend a hand of healing. And so as you end your time with us here today, what we'd like to do is leave you with a little bit of inspiration and a touch with the Spirit. And so what I think about when I think moving beyond coping to hoping is that's a leap. Who wants to cope? I mean, would you want to cope? That's using the image of our heart. Cope in my mind is sort of like this, just sort of getting by. And for those of you in the audience that know anything about the physical heart, when the line is like this, not so good, right? What hoping is acknowledging that life is like this, and that there are struggles, and there are perhaps setbacks, and there are physical ailments that come into our lives that might bring us here. But we don't want to stay here. We want to hope. And what we know, I didn't bring any statistics, but we know that if people have a spiritual sense of hope and gratitude, their outcomes are better and their healing takes less time. We know that. So what we'd like to leave you with is an opportunity to hear from people who have made some choices and also experience the support of others to move in their own life beyond merely coping to a sense of hope. So I'd invite Dick and Aaron, if you would, come into the living room of all of these fine people. So Aaron, you graciously shared your story earlier this morning. So Dick, if you wouldn't mind just telling us a little bit about your story.
All right. Well, it begins about 5 years ago, but according to the facts about these things, much earlier than that. My father died of heart disease. He was one of the earlier patients here, in fact, for bypass surgery. And his father had died from heart disease as well. So I knew that I was eventually going to face that prospect, but I thought that it would be much later in life than it was for my father. He was a little short of his 63rd birthday, I think, when he had bypass surgery. I lived a healthier life than my father, I thought. He was a smoker. I smoked very briefly when I was young, but I gave it up when I was in my mid-20s or so. And he wasn't much for exercise, and I've always been quite active, playing sports and so on. But as a matter of fact, I discovered that I had heart disease when I was 2 years younger than my father, even. It came on in a very sneaky way. I had a bout or two of what are called premature ventricular contractions, which are regarded as benign, just irritating. The first time it happened and was severe, I did go to the emergency room and was diagnosed there. I had another attack about 3 or 4 months later. It was bad enough that I went to the emergency room. As a result of that, I was given a stress test, a stress echo. Everything seemed to be fine. I was then given a heart monitor and a portable kind of electrocardiogram, and wore that for a while. It was a bit embarrassing once in a while. I taught at the university, I still do, and I had to wear this thing while I'm in class, up in front of classes lecturing, and every once in a while it would go off, and it'd start beeping and everything. But the result of all that was negative. But then, and this was in the fall, in the winter of that year, I began to experience a strange feeling in the lungs, like I had breathed real cold air. And over the course of that winter, as walking from my vehicle to my office, which was about 3/4 of a mile, I began to get chest pain, and finally enough chest pain that I had to stop from time to time, and I'd arrive at my office feeling sick and so on. So I went then to see a cardiologist who ordered a perfusion test, and I didn't prepare for it properly, so they tried a treadmill, put me on a treadmill, and they took me off in a minute and a half, put me in a wheelchair, and sent me to the cath lab. And then the next day, I had quadruple bypass surgery. It seemed to be entirely successful, whereas I couldn't walk 2 blocks before without getting chest pain, and I was walking within a few days, 8 blocks, then a mile, and everything was fine. This was in May of 2004. And I went through the rehab program quite successfully, everything fine. I worked up to the level that the therapist asked of me. But in late July, I started feeling a little bit strange again, and went to Great Falls. We were going on a little golf trip up in that area, and stopped by the museum there, and during that time, walking up and down the stairs, I got very sick and went to the hospital in Great Falls, spent the night there, came home. 2 days later, I came into the emergency room here, and we found that 2 of the bypasses had failed. And so the native arteries were repaired with angioplasty, and I've been fine ever since. Except that I have to say candidly that after the discovery of the failure of the 2 bypasses, I lost my confidence in the whole business and became quite nervous about it. And I began to experience something that was described as post-traumatic stress disorder. The feelings of fear would come on me all of a sudden. I didn't feel that I was afraid. I wasn't thinking about anything in particular, but I'd be in a class lecturing, and all of a sudden, heat would sort of creep up my body and like this, and I had to learn to fight this off, and it took me 3 or 4 months to get beyond that. I went through rehab again and continued in what they call phase 3, and then became a member of the wellness center down here so that I could exercise regularly. I walked on the treadmill, lifted weights, did even some running, and got myself in pretty good shape, lost some weight. And everything has been fine since then. I've gone elk hunting, done very vigorous exercise. I, once in a great while, still have a very slight bout of this irrational fear, but I've learned to deal with it and to get beyond it. So that is my story. Now, as for some other things that I've been asked to talk about, what have been the problems, the things that have been most challenging for me? Well, I had to change my diet quite radically, you know. I think part of the reason that I beat my father to the surgeon's table was that I did a lot of lunches at places like McDonald's. You know, I liked hamburgers and French fries, and the thought of a hamburger now kind of makes me ill. I never do that anymore. Controlling my weight has been a problem, partly because of my occupation, I think. I've been asked to say what's been most instructive about all of this. It's hard to say. I've learned a lot about heart disease and about the anatomy of the heart and things like that. But what I think has been the most instructive to me is that I have come to appreciate, even more than I did before, the value of life. When you're young, and 60 nowadays is really pretty young, provided that you're healthy, you know, you take life for granted, and you feel like, well, death is way off in the offing there someplace, and you know, you have a rather blasé attitude about things. But when you come up face to face with your mortality, as I did, then each day becomes more valuable. You become grateful for the opportunity to live that day, as you are grateful to the people who saved your life, as the surgeons did. Not only the surgeons, but the nurses here were wonderful, and the rehab people were wonderful, the entire staff of the hospital. And I'm very happy to say that I've had some very good days, wonderful days. In the time since my heart disease, both my daughters have given birth to granddaughters who are wonderful. And it's been, in many respects, the best time of my life. And I look forward to many more such days and many long years. Marianne talked about hope, you know, and coping and hope. Well, first you have to cope. You have to learn to deal with your disease and get to the point where you can live a fairly normal sort of life. And that seems to me to be successful, to be happy, to be contributing, to be doing some good work, to be a valuable member of your family, and I hope that that's the case with me. And I do have hope. I have hope that I will live a normal span of life, and that's, in the end, I think, all that one is really entitled to. Thank you very much.
So Aaron, perhaps you could talk a little bit about your challenges and then make the connection between the challenges and what's been inspiring or hopeful for you.
I would agree with everything that Dick ended his speech with. And I too have times where I feel afraid a little bit. I'm a frequent flyer, as they call it, here at St. Pat's, just because I do listen to my body, and I know that it's not prudent to ignore things that could pertain to my heart disease. So I come in and check it out, and I've had so many heart caths that I think they ought to just kind of put a plug in my groin with a cork in it or something. Speed things up when I come in the next time. But as you can see, I'm a happy person, I'm an engaged person, and as I said earlier this morning, every morning I wake up, I'm glad that I'm waking up. I think probably the most meaningful thing that has occurred for me in this experience has been to deepen my gratitude for everything. Even those things that can come to us that look negative or that look bad, or that we call challenges, there's a gift in every one of those experiences. And my heart disease has been a gift to me. It's been a gift to my family in that it was a wake-up call. I have 5 boys, and I raised them mostly by myself. When they came here to spend those 5 days in the hospital with me, they began to realize that I'm not as tough as they thought I was. And so they're appreciating me and life in a richer way also. One of the things, though, that has given more meaning to my life has been my involvement with the Mended Hearts organization. And Mended Hearts is a national organization that started almost 60 years ago, and the chapter that we have here at St. Pat's, it's comprised of people who've had a heart event, either surgery or a heart attack. And certain of us are trained to visit people on the heart unit here. I was visited when I was a patient here by Elmer, who I still get choked up thinking about how much that impacted me. Someone who had had a procedure like I had, smiling at me, telling me that I can make it. And now I get to do that for other people. And that means a lot to me. It means a lot that I can still contribute and give back. It means more than ever. I've told you this morning that I've been a nurse for 37 years, but this is some of the most rewarding work I've ever done. And I do want to say, if you've never been a patient here, it's something to look forward to. There's a healing environment in this hospital that I've never experienced in any other hospital, and I think it's probably because it's a Catholic hospital. So it's okay to, to say God bless you, and it's okay to say that, God plays a role in our healing. And so this place meant a lot to me, to have the kind of environment to begin my healing. So I count every day as a blessing. And I try to be really present every day to just wring out every bit of meaning that that day can offer, and also to be conscious of opportunities to give back to other people. So, I'm not always on top of everything. I can have my moments of fear and anxiety too. But overall, this has been a blessing to me in many ways. So if any of you are anticipating having a procedure here, or know that your family history may point you in that direction, I say to you that it's going to be okay. That you'll get all the help that you need here, you'll get the best of help that you need here, and that you too can find a way to make it through here, and hopefully it'll be your turn next to give back to someone else.
So Erin, you had some very specific little pieces, little nuggets of advice mixed in there, and I hope you picked those up. And not just if you are experiencing heart disease for yourself or your family members, but just for life in general. Some very specific, and I'll name those in just a minute. But Dick, wanted to give you a chance to share a little bit of wisdom in terms of what advice would you give the people here?
Well, I feel presumptuous giving anybody advice or pretending to have wisdom, but I'll I'll speak a little bit from my own experience in case it should be of any value to anybody. I think that it was important for me to learn as much as I could about heart disease and its treatment. I read some books. I remember one book in particular which was, I thought, especially useful. It's called Track Your Plaque, and I can't remember the author's name, a doctor. My wife is in the back. I'm sure she'll know. And so you need to take an active approach to your treatment. Once you come through the surgery and so on, become involved, not passive, not just expecting that the physicians are going to fix you. You have to do much of it yourself. And that begins with the rehab process. We have a wonderful cardiac rehabilitation unit here. You have to pitch in and do what you're asked to do more. Take yourself to the limits. I know it requires some courage, but don't be afraid. Get in and do it. That's the only way that you're going to really overcome this problem as best you can. And of course, follow your physician's instructions, take your medications, even though the effects of those can sometimes be a bit unpleasant. Finally, I would say this. I wished that Elmer had come to visit me when I was in the hospital, so you should welcome such people. Instead, I had a friend come in to see me right after my surgery. I was sitting there at the time in a chair. They get you up as soon as you can, you know, and I had the gown on and this horrible scar and everything. And he begins to tell me about his father's experience. He said, you know, my dad had heart problems too. He had a heart attack and he was in the hospital for a month, and then he sent him home and said, avoid excitement now. And there he was one day watching fights on television, and he jumped up and said, hit him, and just like that fell dead of a heart attack. If somebody comes, my last piece of advice, somebody like that comes to visit you, boot him out.
Do not be passive. Learn what you need to learn. And in a couple of different ways, one of the things that really struck me this morning is, did you know that your heart was connected to your head? Yes. that physical heart can create your head, or can put stuff in your head that really makes you crazy. But conversely, you need to educate that head so that then you come back to a place, and again, Dick used the word courage. The word courage happens to come from the Latin word cur, which means heart. So courage is about the heart, and not being passive is about the heart, and learning and being able to take care of those thoughts in the head are an important piece. A couple of little things. I forgot the gentleman's name that came to, how could I forget that name? The man that came to see you in the hospital.
Elmer.
Elmer. What a wonderful name, Elmer, and I forgot it already. Elmer. Remember Elmer. And what is it about Elmer? We need people. This isn't something we do by ourselves. We need people who care. Whether it's someone like Elmer that you've never met before in your life, or the people in our lives. And whether it's heart disease or life in general, we need people who are positive and hopeful and uplifting. And maybe a final little word to go back to what Dick said. If someone comes in and is negative and not so good, kick them out. Because moving from coping to hoping is about being positive and recognizing that every day is a gift, and every person we meet has something to share with us. And learning and growing, we're never too old for that. And don't be passive. Be engaged in life, and all those other things will happen. So it's not about coping, it's about hoping. Okay? So thank you very much for your time. Dr. Knapp, closing words? Thank you. Thank you.
Okay, well, thank you all for coming. Thank you all for staying, and we'll see you next year.